Hello, welcome everyone. Welcome to Book at Lunchtime in week 7 of Trinity Term 2023. I shall come back to 2023 as a date in a moment. Today we'll be discussing Professor Josh Hordern's new book, Compassion in Healthcare, Pilgrimage, Practice and Civic Life. For those of you new to Book at Lunchtime from Torch, it's one of our longest standing flagship events. We have films of every book featured going back to 2013. So Book at Lunchtime is 10 years old, as is Torch itself. We have a growing history and heritage, and we celebrate it each term with these Book at Lunchtime events. We are then celebrating 10 years of Torch this year. This event is part of our Torch at 10 celebrations, not least because Josh has just told me this Compassion in Healthcare project began in this very room 10 years ago. So it seems right to be here today. Today, then, we are privileged to host Josh and an expert panel to discuss questions arising both from this book and from the larger project of which it's a part. Josh is very much an old friend of Torch, was what we like to call an early adopter of the Torch ethos and Torch practice, and is a key member of one of Torch's most high-profile programs, Medical Humanities. And it's nice to see Erica and others from the Medical Humanities program here today as well. Josh is also Professor of Christian Ethics in the Faculty of Theology and Religion and a Governing Body Fellow of Harris Manchester College. Alongside Josh today, I will just very, very briefly introduce our panel members. I'm sure they'll say something about themselves and their work in due course. Angeliki Karasidou, an Associate Professor at the Ethox Centre here in Oxford and a Research Fellow at the Wellcome Centre for Ethics and Humanities. She's also a Fellow at Reuben College, where she leads the Ethics and Values team. Welcome, Angeliki. Dr. Richard Hain, a consultant and clinical lead at the All Wales Managed Clinical Network in Paediatric Palliative Medicine in Cardiff and the Vale of University Health Board. Welcome, Richard. Dr. Graham Collins, consultant haematologist and lymphoma lead and an associate professor of haematology. As I say, it seems appropriate to be hosting this discussion here in this room, not only because it's the old Radcliffe Infirmary, and indeed one of the original operating theatres, but also, as I said earlier, because this is where this project began. For me, it's also, if I may say, particularly interesting to be listening to this discussion, because my first book and my thesis was all about pilgrimage, albeit in the 16th century. But there was a great deal of compassion involved in my discussion in that book, or an argument about what compassion constituted in the 16th century. So I shall be listening with even more interest now, as I think you guys don't need the mic. You people don't need the mic because you're mic'd up. But thank you for coming, everyone, and I'll hand over to Josh now.
Wes, thank you so much, and just want to pay tribute to Wes in particular and the Torch team for the way that they've cultivated a tremendous community of research and public engagement in the humanities and beyond over the past number of years, and very grateful to Wes for your kind introduction. As Wes said, this project started in this room, which when I booked it 10 years ago for a seminar, I didn't realise was in fact an operating theatre. And one of the people who was there at the time, Anne Bradshaw, who I learnt a great deal from, an expert in nursing from Brookes, told me that that was the use of this room then. So I've been learning ever since from those working in healthcare. So we're going to talk a bit about this book today, which is newish, I'd say. It came out really during the pandemic, and therefore it didn't have perhaps the launch it might have done during the pandemic. So this is a very nice occasion for it to be able to get a bit more of an airing. So what I want to talk about first is what I say about compassion, or really the question, what is compassion? It's a very vague and slippery term in lots of ways. Here's a question, here's an answer to the question, what is compassion? This came from a nurse who I listened to. The nurse said, it's hard to say what compassion really is, but I definitely know when it's missing. And I thought that to be a very, very interesting starting point for my learning. And I was trying to learn from all sorts of people in healthcare and especially from patients as I was going along thinking about this topic. And so the question followed is, how might we learn about relationships of compassion and even learn to be compassionate, if that is a possible idea? So as I say, I went about learning by doing lots of listening. It's something which is a very precious thing in human life, is to be able to listen, and I'm still very much learning to do it. And who was I listening to as I was trying to think about this project of what compassion in healthcare might actually mean, what it might be? I wanted to listen to contemporary companions, those who I was actually with, those who are working in healthcare, those who are patients, others who I was learning from. So contemporary companions, and also to ancient but living traditions. So we might think that talk about compassion, very current as it were in the NHS and other health services around the world, but actually the theme of compassion is a very ancient one, and Wes just referred to the way that compassion was part of his work on the 16th century. I was trying to think back to Aristotle and Plato, and then forward through other traditions of thought about compassion and practice through history, in order to have both, as it were, ancient companions and current ones. Now, how did I get interested in this whole theme in the first place? A bit of background might be helpful as to where my learning has been earthed. I married into the NHS, a bit like marrying into the army or the military more generally, as those who are engaged in the NHS know. So understanding a lot from my wife's work in obstetrics and gynecology, but then from a series of collaborations with clinicians, healthcare staff, patients. And here are a list of those collaborations. One was with the Royal Society of Medicine here, and that was really the first Torch-funded project, which took place with the encouragement of Stephen Tuck, who was the original, I think, director of Torch. And then, as part of that, a number of folk got involved, one of whom was Richard Hain here, who was part of that initial seminar. People from healthcare, from philosophy, from theology. Anne Bradshaw I've mentioned, and it's wonderful to have expertise from nursing here today. And then Angeliki, who we collaborated together on a project on marketisation in healthcare, not just thinking about, as it were, the individual, as it were, patient encounter or encounter between colleagues, but actually what's the overall systemic environment in which the term compassion or the practice of compassion is operating. And then other colleagues around the country, or in Oxford, like Katie Southwood here, we worked together on themes of responsibility, compassion. Roger Newham came up to Birmingham, learnt a bit with Roger, and also other conferences where we've been working together. But behind this project was an AHRC, Arts and Humanity Research Council, bit of funding, which really was looking to fund a kind of very engaged practice of humanities, and theology in particular, working with the Royal College of Physicians up there on their work on professionalism, what professional identity might mean for medics in particular, working with Oxford University hospitals, with a number of different departments around those hospitals on the theme of compassion, compassionate practice, and Graham's department in haematology was one of those. And then a precision medicine outfit, stratification in colorectal cancer, because I wanted, as it were, look into more of a kind of high-spec, high-end, more technological approaches to medicine in the sort of precision medicine space. Just one example, of course, in cancer and in cystic fibrosis. And ask, well, what does compassion mean across the kind of ecosystem of that area of healthcare, from lab researchers to patient groups to politics to economics to the actual practice of medicine. So those were the kind of environments I was trying to learn within. Just to be a bit more specific, at the John Radcliffe and the Churchill, I was working with staff. I don't know if Nicola is here today. Nicola de Savary, she had signed up. I don't know if she's made it. I can't see her. But Nicola in gerontology, Graham in haematology, and we co-designed some seminars on compassion. And in those sessions, I was learning alongside people working across different departments, different specialties, listening to their ideas about what compassion meant, and how they did or did not experience it, participate in it, and so on. So that was nurses, medical secretaries, I found medical secretaries especially helpful in shaping my thinking. Healthcare assistants, doctors, midwives, pharmacists, occupational therapists, physiotherapists, lots of interesting cross-cutting collegial relationships. So I was asking questions about what compassion meant to them. The strapline of Oxford University Hospitals is delivering compassionate excellence. At least it used to be. I think it still is. Is it, Graham? Yeah, not nodding there. But what does that term mean? What does the value of delivery mean? What does compassion mean in the actual nitty-gritty of practice? Then out of that, some work with Royal College of Physicians. They had some work ongoing called Advancing Medical Professionalism, in which Louis Fuchs, who's here, was so helpful in bringing that report to light and to making it usable for clinicians. And then turning that project into a medical education project for Oxford undergraduate students. And that's especially involved. Here's Nicola, wonderful. I was just singing your praises. There we go. Nicola's here. So Nicola's one of the colleagues who I learned from initially. Great to see you, Nicola. So in the medical education space, what does medical professionalism sort of focused, for me at least, around the theme of compassion? How do we actually do something about that which helps medical students to prepare for work? And colleagues who've been particularly helpful in that, Sally Frampton and Ariel Dempsey, and maybe others around the room who I'm forgetting. But very much a collaborative team effort, lots of people I've learnt from. And again, in precision medicine, that was really thinking about how the journey of patients through the world of precision medicine, which can be quite fragmented and challenging to navigate, how that could be done surrounded by compassion. And again, a particular colleague there, Therese Filer, who's not here today, was particularly helpful in that. So what did I, this is the kind of environments I was learning from. What did I hear? What did I learn? Well, here's a bit of a word bubble around the theme of compassion. These were some of the terms which people wanted to bring out onto the table to say, this is my kind of connection to the theme of compassion in my workplace. These all come from an OUH context in that MDT multidisciplinary team setting. And one of the things I noticed was the importance of compassion as a kind of social event, less a kind of character trait of an individual, more a kind of social event or team event that people wanted to participate in, to have a kind of compassionate culture that you share in and that you join in, as opposed to depending upon the particular, say, virtue or character strength of an individual. And that was quite interesting for me to learn about. So the way of sort of thinking about that practically is to think about collegiality. How do colleagues work together and learn from each other and care for each other? I expected to be thinking a lot about compassion, as it were, to patients. I found it was much more multi-directional than that. Compassion between colleagues, often in short supply, actually, sadly, but actually then the compassionate relationship between patients and clinicians, and of course patients in patient groups, especially in rare diseases. So those were some of the things I learnt about. But then just to flick on a little bit further, here are some of the comments that some of the folk make who were part of that exercise, which recognise the benefits to them, at the time at least, of engaging in these seminars. I just highlight especially the Ward Sisters comment there, the challenge of being compassionate towards each other, and that being very much the lifeblood, or the needed lifeblood of many of the departments I was learning from. A number of things there to consider. More broadly, as I said, this RCP activity, we were trying to think about the different domains in which doctors needed to think of their lives and their vocations, their professional identity at the current time. So quite focused on doctors, but very much doctors as part of a wider team. One of the things we really wanted to emphasise was interprofessional relationships. A number of things we could highlight there. I just want to highlight the first one, doctor as healer, making quite a strong differentiation between cure and healing. Cure often isn't possible, and we need to learn as a society, as a community, how to live together in a context where cure is not possible. Just briefly autobiographically, my own mother was, had a very rare kind of bone marrow cancer, perhaps cared for by some of Graham's colleagues in the haematology world, as she would have been had she lived. But she died young. She died at age 33. I was just 5. And I think what resonates with me out of this report is that the cure isn't possible often. Healing, the kind of healing presence that a community can have for people over time, including healthcare practitioners, can be immensely valuable over the course of a lifetime. So that kind of distinction we were trying to bring out here, as well as many more technical matters perhaps around innovation, management and leadership. So just going on a little bit further, this was the stuff in precision medicine. What I noticed especially was the kind of culture of promise, of promissory medicine, which was very much operating in that space and probably still is in some ways, and for good reason, that there is great promise in this area of biomarker-based medicine. I'm a little bit out of date now. Perhaps Graham could bring me more up to date because that's more your world. But the point was that in light of our uncertainty promises, the expectation of cure, or the expectation of a personalised medicine specific for somebody with a particular form of cancer, always involves uncertainty. And the challenge then is that promise can always be distorted into hype. And yet promises, and indeed a hype culture, can shape how people live, what they consent to, what clinical pathways or they agree to go down, what career planning. I was very interested in the experience of lab researchers, what was their experience working in this area of medicine, and so on and so forth. Government spending, very interesting part of this context. That's just briefly in there. So what did I learn, as it were, in all this? I learned to think about one particular term. I learned to think about compassion in terms of pilgrimage. And I won't say a great deal about it now because I think others might want to say more. And in a moment I'm going to hand over to Graham and Richard Angeliki, who'll be kindly commenting on any parts of the book they found interesting. But I learned to think about compassion in terms of pilgrimage, not referring, as it were, to journeys to religious places. This may be more what Wes was working on in the 16th century. I don't know, I'd be interested. But instead, journeys of purposeful companionship through life, especially, but not only, amidst illness and suffering. And that proviso, but not only, is important, I think, because companionship in healthcare, which is compassionate in my terms, doesn't always involve illness and suffering. We could talk about that if we wanted to, or at least not primarily or predominantly illness and suffering. So what do I mean by pilgrimage? Very briefly, it's a way of imagining individual existence and social experience together, how we are as individuals, how we live life with others. It comes from ancient classical and religious sources, Jewish, Christian sources in particular, and the big idea is wandering or wayfaring away from one's home. So being away from home, that might mean different things to different people. Maybe being in a humanities building for a clinician, although of course, as we'll learn, this was actually your home before it was ours, Graham. But being away from your hearth and home, being away from a place where you feel at home. Much healthcare, of course, not all, happens away from home. Hospitals, hospices, of course we now have increasingly hospice at home, which has changed the dynamic again, and many other forms of health visiting. But much happens away from home. And for many people, such institutions, however good they are, may feel quite alien and difficult places, not places which they want to define life's journey or life's ending. So welcome is offered, but a hospital or hospice is, as it were, an inn on the way rather than a home for good. And for some, perhaps for some here, home may have a greater resonance, not only hearth and home, but a place of rest and peace which lies beyond this life. So the talk of peregrinatio is to talk about being away from home. It starts to signal the strangeness of healthcare. There's an experience of being unwell, often, not always, experienced as alien and unwelcome intrusion. We need to be careful around that. But peregrinatio also helps us to think about the human condition as transitory, which for difficulties of life, including ill health, bring to awareness. And crucially, at the heart of ancient and religious notions of pilgrimage is companionship. This is not a solo endeavour, but a companion endeavour. in the context of healthcare, the structure of institutions is intended at least to be such that you don't travel alone. The idea is of a purposeful journey through life, often amid suffering, with others. So those are some things I learned through observing and learning and listening and trying to frame from ancient living traditions and from contemporary companions something around compassion. I don't want to wander too far into the territory of my colleagues here, so I'm going to hand over to them and see what they have to say for a few minutes, and then we'll have some conversation. Conscious of a lot of wisdom in this room, which we can draw into conversation as we go along. Graham, I'll hand over to you.
Thank you very much, Josh, and thank you very much for asking me to come and speak. So my name's Graham Collins. I'm a haematologist, consultant haematologist up the hill at the Churchill, and an associate professor in the university. I really only treat one type of cancer now, so something called lymphoma. So if you've got lymphoma, I'm your man. If you've got anything else, I'm not, and much to my family's despair. And really my interest in this whole area first came about really when, about the strapline that Josh mentioned with OUH, Oxford University Hospitals, that delivering compassionate excellence. I think I'd been a consultant about 3 years, and I'd probably had a bad day. And so I was sort of reflecting, I think slightly cynically, what did it mean to deliver compassionate excellence when you've got, 20 minutes in a consultation to tell somebody they've got, 3 months to live and they need to sort out their affairs, and, or maybe you've got somebody with a disease where there's a really good treatment, but the NHS doesn't fund it. So, how do you sort of get that conversation across in a compassionate way? How are you compassionate to your registrar when they ring in sick and you've got nobody to cover the night shift? All these things really are real life, quite frequent events in the NHS. And how on earth do you bring in a compassionate element to that? Fairly shortly afterwards, Josh contacted me with this idea of exploring what it meant to have compassionate relationships within departments. And we had, I think, a very enjoyable 3 or so meetings, I think, where we discussed that and tried to apply it. It certainly had its challenges, particularly applying that to actually evoke some change in the department. But it was a really useful experience as a whole team to discuss what it means. And I think, when this book came out, I really saw it as a distillation of that project and obviously a number of other projects too that Josh was involved in. And I've been very grateful to have a copy of the book and to read through it. And I think the bits that really struck me that I'll just draw out a couple of things. The main thing is around compassion as pilgrimage. Partly it's nice to learn, I assume it's a Greek word, is it? Peregrinatio? Latin, oh dear. That's you can see my humanities training ended at history GCSE, so yeah. So I found it a very helpful concept of a pilgrimage or dealing with wayfarers, if you like, in life's journey as a way to frame consultations. So I probably have about 20 to 30 individual consultations with patients a week in outpatient clinic on the ward. And what I find helpful about this concept is I guess it focuses on the humanity of that relationship, that there are two human beings, without the sort of, thankfully, without the sort of patriarchal approach that used to apply to medical consultations. But within that concept, it does allow people of two different narratives to come together, contributing different things to that relationship. So, as a medic, obviously I'm soaked in the science, the clinical trial results, the experience of patients having chemotherapy. That's what I sort of bring to the relationship. And obviously the patient brings their own narrative, their desires, what they want out of life, their experiences of other people who've sort of traveled the journey of cancer and chemotherapy. And that sort of meeting of human beings in that relationship I found very helpful as a way to approach consultations and a way of how to perhaps improve the experience of both parties in those consultations. A couple of things that I think flow from that idea, which again are drawn out in the book, which I found very helpful, is to try to avoid making compassion acquiescence to whatever the patient wants. And that is certainly a theme that has been around in medicine, that we're here for the patient knows best, and clearly there is a truth in this, but it's limited. It's limited. The patient comes with certain perhaps preconceptions around the disease they've got, the treatments that we're offering, which may not be right or may need information. And in order for them to make an informed decision about what we're suggesting, there needs to be a degree of education and sometimes even persuasion within that context. Now, it got me thinking when I was sort of thinking about this, in what way do we invoke persuasion in consultations, and is that a right and compassionate thing to do? And it brought to mind a patient that I had probably about 4 or 5 years ago now, who came to me with quite a treatable form of lymphoma, not curable, but treatable. And the treatment, which was chemotherapy, would lead probably to a good, 6, 7, 8 year remission, good quality of life, really, really quite a sort of good outcome. But she was adamant she did not want chemotherapy. And of course, the first thing we do is we ask why. And her reason was, it was quite surprising actually, to me at least, her reason was that there was basically a conspiracy from pharmaceutical companies that the only reason we give chemo is they've sort of duped us into thinking that it works, whereas actually it doesn't work and it just leads to toxicity. And she was perfectly competent. Her reasoning was sort of rational to an extent, even though I disagreed with it. And so the question we were faced with as a team, wasn't just me, it was the specialist nurses particularly as well, was how much do we try and talk her out of that? How much do we try and persuade her that that is not a wise thing to do? Now, of course, in medicine, we're brought up with a concept that patients have the right to make the wrong decision. That maybe sounds a slightly arrogant way of putting it, but that's a reasonable thing to have in your head. Ultimately, the patient has a legal right to make a well-informed, autonomous decision, and we can't override that, absolutely. But how much can we persuade, not just inform maybe, but persuade the patient to think that there may be another route that is perhaps wiser? And we did, I think, have a reasonably vigorous discussion and indulged in persuasion to try and bring her round to our way of thinking. We asked her if she wouldn't mind bringing her family with her in the next consultation, which she did, and the family were also trying to persuade their family member to have the treatment, but in the end she refused, and obviously we had to support that, and she did sadly die, in my view, much too early, really. And it did get me reflecting, did we do the right thing? Was that a compassionate response to her illness and her wishes? In some senses, yes. If she does make that decision, it's only right that she does it fully informed. But on the other hand, did we actually make it a more difficult process for her to say no by being, sort of embarking on that route? I don't know, I'd be interested to hear your thoughts. But I think the narrative of compassion being a pilgrimage, being a coming together of wayfarers, if you like, in life's journey, is very helpful, and it does allow that room for an avoidance of just acquiescence always to what the patient wants, which I think can be very unhelpful. The other thing I think it avoids, sorry to focus on negatives, but the other thing I think it avoids is healthcare becoming transactional. And I think this is partly how some areas of healthcare, how that is becoming, and it does worry me a great deal. So what I mean by that really is, you're just treated as the next person with a problem to solve. You solve the problem and away you go. And there is an element that some healthcare associations are like that. You've got a chest infection, you need antibiotics, they're prescribed. Okay, that's a fairly transactional relationship, and potentially that's all you need. But in the form of a more chronic illness, I think that can be extremely unhelpful, both for the healthcare professional and for the patient. And what I mean by that, take the example of junior doctors' contracts. Now, this was a very big deal a few years ago. It's actually quite a big deal now with the strike action that we're seeing. And quite rightly, the new contracts that junior doctors have limit their working hours. Now, that's really important to maintain patient safety, to maintain health amongst our junior doctor workforce. But what it has led to is a focus on rotas being shifts. So a doctor turns up, does their shift, goes home, maybe have the next day off, turns up, does another shift, maybe on a different ward, maybe with a different team, almost certainly with a different team, and almost certainly with a whole different group of patients. So that aspect of continuity is being eroded. And I think that's in a way an inevitable consequence of the way that healthcare, at least within our junior doctor colleagues, has gone. The problem with that is it does lead to a dissatisfaction in the career of medicine, and many of my junior doctor colleagues do voice this. I also look at my own career, where I am now, and I'm really blessed with having wonderful continuity with my patients. And whilst I do work very hard, quite long hours, I find it very invigorating to have those ongoing relationships with patients throughout their sort of life course, whether that be treating the disease that cures them and we discharge them from clinic 2 years later, fantastic, or whether that be patients who develop refractoriness to chemotherapy and sadly die of their disease, and with all the sort of consultation, communication that goes around that. It is very satisfying to me as a healthcare professional to have that ongoing pilgrimage, I guess, with the patient. But, and I think it is important to try to, where we can, promote that sort of pilgrimage style to healthcare relationships. As I say, it's not appropriate necessarily everywhere, and there are real threats to it, but I would certainly be very keen to promote that in a healthcare environment. So just a couple of thoughts. I've got many others, but I'll stop there for the sake of my panel members. Thank you.
Thank you. So I'm Richard Hayne. I'm a paediatric palliative care doctor. So I'm a paediatrician. In fact, I'm originally a paediatric cancer specialist. And I then went into palliative medicine. So I just look after children with life-limiting conditions now. And it seemed to me that there were three big ideas that came out to me. And the first of the three big ideas was the existence of the book at all. This represents Josh's claim that moral theology has something to say to modern medicine in a secular age, and by secular I mean the way that people in this modern age use the word secular, in other words, a non-religious age. And I think he makes that case really well. It's extremely important that we subject moral ideas, moral reasoning to the same kind of rigorous analysis, same kind of critical review that we routinely do with data. And I think, I don't know what your experience has been, Graham, but mine has been that clinicians don't always do that. They will look at a piece of data research and look at it very carefully and critically. If somebody tells them something ethically, they'll just say, oh yeah, that's fine, and they won't even necessarily interrogate it. And so we get Staffordshire issues, we get the Gosport issues, we get the Liverpool care pathway, where people just haven't thought through. The moral reasoning has not been rigorous and robust. Nobody could say that about this. And the other thing is that Josh doesn't talk down to clinicians, which sometimes ethicists and moral philosophers do, but he doesn't try to pretend to be one either. He just does what he does really well. And I think that's extremely important. And that dialogue between moral philosophers, moral theologians, ethicists doing that job really well, and clinicians bringing their expertise and doing that job really well, and the dialogue between them is where medical ethics needs to go. I did my DPhil actually with Josh and with Nigel Bigger on infanticide, which my specialty is children's palliative care. That was very important. People who are pontificating on infanticide, people who've published on infanticide, it was quite clear they knew very little about infants. They knew very little about what children are or what newborn babies can do and can't do. And yet they were making these plonking conclusions which were affecting the way people saw children, the way children should be looked after. So I think it's really important. I think it makes the case for itself. It's really valuable. The second of the two big ideas is obviously peregrinatio. I teach palliative care, obviously, and as you know, pallium from the Latin, a cloak, and I always teach, palliative care 101 is what do we mean by pallium? Why is it palliative care? And most of the people I'm teaching on that will get the first of those, which is that it cloaks symptoms, it hides the effects of a condition, and of course that's true. But I always press them on a second meaning of that. And I get them towards this idea, and this is long before I met Josh and had any idea of what peregrinatio meant. I press them on the idea of two people walking along side by side. One of them has a cloak, one of them is cold, and the one with the cloak shares the cloak. Now that actually is just a little metaphor for sharing suffering, and that is really what palliative care is about. And I think this point that Graham made, that we can't always cure things, we're never going to be able to cure everything. If we say that all that doctors can contribute to the well-being of other people is cure, then actually we're including ourselves out of a lot of things, a lot of the care that people need. So I think peregrinatio, absolutely right. Very interesting combination of two things there, the companionship, but also the issue of wayfaring, which I still need to think more on, because I think that sense of purposefulness that you give that feels to me quite a uniquely Christian view, or quite a religious view, and how that translates into everyday healthcare, I don't know, except that on the whole, it is the way that people actually see things. They see themselves on a journey. It's a metaphor that works. So the third big idea is obviously compassion, and I really liked the fact that Josh says, look, compassion arises because you've got people caring for one another. That's what peregrinatio is. If you see it like that, it's interactive, it's interrelational, then you realise that that you can describe what compassion is like. He says the nature of compassion, but you can't actually say in any given interaction between two given people what it will contain. He described it once to me as it's a container of ideas rather than an idea in itself. And I think that's absolutely right. I think that makes complete sense. I did have some reservations, however. So the first was that I didn't really get the reason that you quoted Smajdor. One of the things I should say about Josh's work is it's very dense, and he's so fair to all the people that he draws on that sometimes I emerge thinking, I'm not sure whether this is Josh talking or whether this is the people that he's representing so very fairly and critically. And I wasn't sure, Josh, whether you agreed with Smajdor, if that's the right pronunciation, who said that compassion, for a doctor to show compassion, is actually a bad thing. And if I've got this right, it was because Smajdor reckons that it implies that the doctor is doing something for the patient, is that the doctor is elevating him or herself above the patient. Now, it seems to me that that is fundamentally wrong, because if we're representing compassion, as I see it, the compassion that a doctor feels for a patient is no more than one example of the compassion that any human being should show for any other human being, and possibly other beings who aren't human. In which case, this is just, a plumber is showing me compassion when I need a good plumbing job done. I am showing compassion to a parent of a dying child because that's what they need in that moment, and I'm in a position to help. So it feels to me that there's no reason for us to single out this interaction as though it were a fundamentally different category in some way from other compassionate interactions. And I think that probably also relates to you resisted the idea that compassion was the same as agape, the Greek idea of agape, but
One concept of agape. Yeah.
Okay,
Yeah.
fair.
Yeah.
Well, and I think actually the concern that you had was that agape, if we actually set agape as the standard, it is an unreachable standard in practice for us to maintain. If we actually cared as much for every single person that we were interacting with as though they were ourselves, as it would be utterly exhausting. We wouldn't be able to manage one patient, never mind. And I think that's true, but maybe then it's fair to say that agape is the perfection of compassion. But actually, it feels to me that it's of the same stuff. That compassion is, and agape, the conception of agape perhaps that I have, would be the perfection of compassion, and that you can have compassion without necessarily having agape. I didn't get why compassion should be contingent on desert. And I think you turned to Nussbaum, I think, for that, wasn't it? Have I got that right? You're going to come back.
I'll reply.
And I'm uncomfortable with that. I can't see that So one of the things I'm very interested in is language, and so I had always thought empathy, compassion, those two things are cognate in a sense, and I was amused to realise that I was completely wrong. You probably already know this because you're all humanities scholars, that the word empathy is actually a made-up word, a Greek made-up word only in the last century, and it was a Greek-English translation of a German concept, Einfühlung, and which means in feeling. So in other words, empathy doesn't, as I thought, stem from a Greek version of compassion, which is obviously Latin in its root. I thought they both meant suffering with, and they don't. Empathy is actually quite a forensic surgical term. It literally means you are feeling, or you are trying to feel what somebody else feels. And it feels to me that that clearly doesn't rely on, that on its own isn't a good thing or a bad thing. But when it comes to compassion, there's no particular reason why I should be less aware of somebody else's suffering if they've deserved that suffering than if they haven't. And it doesn't feel to me that that compassion is therefore contingent on that. So the sequence I'm making there is empathy is not enough on its own. It needs to be linked with goodness, one of the points that Josh makes. If you like, empathy plus goodness of heart are constituent parts of compassion. It's not clear to me why either of those is contingent on desert. I'm also not clear by what authority I would restrict access to healthcare on the basis of desert. So I'm nervous about that. The other thing, one of the things I really liked, and I've liked it in the past, Josh, is the idea that in some way, because as medical students, the first thing we're introduced to is a dead body, that somehow that colours our whole idea of medicine, almost as though death were the goal. And although I really like the conceit, I'm not sure that it makes sense to me. And I found myself thinking, well, when you're a musician, you start by learning scales. When you're a virtuoso, you don't think that scales are the goal of what you're doing. You're just aware that there was a time when you had to rely on scales, and you may be using scales, but they're part of something much bigger, almost transcendent. And I think that's probably true of our experience, in the early experience in the pathology labs. I don't know what you feel, Graham. So I wasn't convinced by that, and I'm not sure. My experience as a palliative care doctor has been that actually doctors on the whole, healthcare workers generally on the whole, actually regard death as an enemy, even when actually that enmity is of no further value and is no longer valid. So I think those are the quarrels I would have. But I would want to return to the fact that we really need more books like this that subject important moral ideas to really careful analysis and express them clearly. Thank you.
Great. I should say thank you very much as well for inviting me to read the book and engage with it and invite me to be part of this panel. Very briefly, I was introduced. My name is Angeliki Kerasidou. I'm an associate professor in bioethics. My background is also in theology, although I haven't really practiced theology for a very long time. And we've crossed paths with Joshua before, working particularly on the marketization problem and kind of my reflections around more about empathy. So I'm going to be kind of riffing a bit on some of the things that you mentioned, Richard. And it was actually at the time as well of the strikes, of the junior doctor strikes, and with austerity and kind of thing, like kind of the systemic issues that seem to be pressing quite hard upon healthcare professionals and demanding too many things. So I'm going to come back to this kind of, and Joshua really kind of talks about this, compassion as a demand. And so what I'm going to do as briefly as I can, so we can have time for discussion afterwards, is kind of offer a couple of reflections, and I will close with two questions arising from my own engagement with this topic. So the first thing I would like to say, very much kind of in line with what Richard and Graham was saying, is like how important I found and how interesting I found reading this book. And I think that it makes not just one, but two important contributions to the medical humanities academic scholarship. So one, and it's very kind of clear one, is that the scholarship kind of makes a huge contribution to the scholarship of compassion in healthcare. Kind of very quickly summarizing, so kind of Joshua starts by identifying what he calls the three ills of compassion, or what is believed to be the three ills of compassion. One, that compassion can be an unreasonable demand, as we mentioned, and that is too much to ask healthcare professionals, on top of everything else, to also be compassionate towards their patients. And within that, there also lies the risk of healthcare professionals causing harm in some way. That this is what Bloom kind of argues, because we tend to be more compassionate towards people that look like us. We can engage with them a bit more, but if they look a bit different or think differently, then like we're not really able to engage with them. Therefore, kind of compassion seems to lie down. So there is a kind of risk there for us to not afford the same kind of level of treatment, compassionate treatment to people that are not like us, but nevertheless to whom we have a duty of care. The second problem with compassion is that it can be vague and indeterminate as a term. And again, the previous panelists kind of alluded to that as well as Joshua in his presentation too. So, and it is not reasonable, the argument goes, to ask healthcare professionals to adhere to a practice and a standard that cannot be adequately defined. So compassion is demanded of healthcare professionals, but without a clear articulation of what it is, then it just becomes a stick by which we hit them, rather than, as Josh says, and I quote here, a disciplined, intelligent agency that can be used to propel healthcare professionals forward in their work. And the third problem, and it is related to the issue of vagueness, is that because it is vague and undefined, compassion is often understood as an acquiescence to the patient's wishes, and understood like this kind of commits the doctor to do what the patient wants. And these problems can often lead to burnout, as Joshua kind of also talks in his book. One can see how being held at a very high but poorly defined standards and being expected to do what the patient wants, even when you might disagree, can make healthcare professionals feel exhausted and stressed and disvalued. And what has been proposed as a fix for these three problems is to get away with compassion and focus on principles like justice and fairness. This is like some of the proposals in the literature, or to think about etiquette and protocols. Yet these solutions, as Joshua points out, are unsatisfactory and also miss the point that makes compassion important in healthcare. So turning doctors and nurses to actors who simulate compassion but don't engage in a compassionate way with their patients is not going to protect them from burnout, nor will it lead necessarily to improved care for patients. And the principles of justice and fairness are not antithetical to the concept of compassion, but in a way encompassed into it. So having identified these three ills that plague both the understanding but also the practice of compassion, Joshua presents his own remedy. So compassion should not be understood as, again, and I quote, element in a periodic table, but conceptualized as a wayfaring or pilgrimage, peregrinatio. And peregrinatio means being away from home, as he was explained to us earlier, being away from the familiar. And sometimes, as he says in his book, entering the strange world of medicine can feel very unfamiliar and strange and scare for people. So when framing peregrinatio as compassion acquires 6 specific qualities, Joshua argues: an interest in human life course, patience with plurality of perspective, curiosity in human encounter and companionship, humility in conversation, recognition of the proper value of healthcare, and perseverance in preserving the communal nature of human life amidst suffering. So peregrinatio, thus understood, envisages people on the road, not defined by places, but by affections, by feelings. So exploring the nature of compassion in chapter 3, Joshua then explains that compassion is one's affective understanding of another person's suffering, dependent on intersubjective communication. So by providing this broader and richer understanding of compassion, what Joshua, I think, demonstrates is that compassion is a pathway to healing more broadly, rather than a road to restoring health understood in a narrow biomedical sense. And again, people have talked about that. It is not a good-to-have add-on, not a function or a practice that can be written into protocols and guidelines. Rather, it is a foundation upon which medicine as a healing profession is built and permeates all aspects of it. So I think this is like the first kind of contribution that Joshua makes to the discussion, to the scholarship. And I think the second contribution this book makes is beyond the scholarship of compassion and more broadly of the field of medical ethics and Christian bioethics. He engages with a difficult question anyone who has come from bioethics from a theological background, and not necessarily Christian, but any religious tradition, would have encountered and grappled with. So how do you do Christian or any other kind of religious bioethics in a secular world? How do you avoid the problem of either only talking to a very select group of people with whom the person shares a religious belief and some kind of eschatological vision, or of becoming a bioethicist with difference, as it's put, where the difference is just an insight into the ethicist's motivations rather than any other substantive intellectual work that goes into the analysis. So Joshua there follows Bigger and more specifically Brereton and argues for faithful secularity. Secularity not understood as an elimination of the theological or the religious, but as a space where various religious and other voices and views can be truthfully and openly examined. Faithful secularity allows for an in-depth engagement in the beliefs and values of others without one being required to accord them ultimate status in one's commitment and convictions. So that kind of goes to your points that Richard was claiming about how convincing that can be for people who do not share in the same religious convictions. The analysis of compassion that follows is one that observes this position, however, I found. Joshua is clear and open about the contribution the theological notion of peregrinatio can bring to the understanding, but also exercise of compassion. He carefully explains how his deeper understanding fits with healthcare as a profession and also as a civic practice, without asking the reader to commit to a specific doctrine, however. So those reading the book who do not share the same religious beliefs will still be able to understand and benefit from this rich exposition of compassion, whilst those who share in the Christian tradition, we will be able to connect deeper with some of the chapters, for example, the one on responsibility, as they will also be able to engage with the eschatological subtext that comes with it. This does not mean that the secular reading of the book is in any way deficient or of a lesser importance, but just that it's different. And like sometimes I think of intellectual work or work of art that it is the viewer or the reader who completes the work. So the creator puts their thoughts there, and then it's up to the person who's coming to engage with them to the depth or the breadth that they want to. And none of this kind of creative work, and writing is in a creative work, is complete until the person engages with them. So in short, what I would say that Joshua's books stand as an excellent example of how to do Christian bioethics I found in a secular world. So, and now very quickly to my two questions. I will try to be very brief because we're I would like to leave discussion time as well. So the first one was, I wasn't very, although the concept of empathy is raised in various aspects of the book, I was not sure whether, and at some point you mentioned that empathy is a skill that connects with compassion, is a skill that is required for compassion. I wasn't very sure whether you still saw it as a different concept, and for that matter, as a useful concept. Because I was thinking, like, kind of drawing from my own work on compassion, and also kind of relied very much on Halpern there as well, is that sometimes I see that empathy allows us to connect and understand in a cognitive and an affective way with another person's feelings, not necessarily feel them in the same way. So like drawing a very interesting distinction there with sympathy, where you can see the person kind of grumbling as well and crying and then not being able to be helpful in that way, but still be able to engage in an affective and cognitive way with the suffering of another person, and then being motivated to do something about it. And it is that motivation that I theorized is compassion. So you first have to be able to engage with it and feel in a cognitive and affective way, and then you act compassionately. And I was wondering whether you still feel, and I think that distinction is important, because then sometimes it can help us differentiate in situations where one can empathize with someone, but feel unable for some reason to act compassionately in that way. So I would like your reflections on that. And the second point that I would like to kind of as a question to raise is, what is the role of institutions and in the general context within which healthcare professionals operate, and their ability to practice compassion? So you kind of very clearly articulate the role of compassion in civic life, and then in chapter 7 about compassion and its role in policy and practice. And sometimes you refer to the kind of underfunded, under-resourced context many healthcare professionals working in the NHS are battling with. But these references come to me as more like a backdrop to provide context rather than as a point of analysis. And I was just wondering, again, kind of thinking of peregrinatio as this kind of wayfaring and pilgrimage. Should people be concerned about the state of the road they find themselves walking on? Is this something that peregrinatio can say, kind of help us think about that? Or then is it like up to the individual to put up with that and try, through understanding compassion as a pilgrimage, to kind of, in a way, kind of put up with the situations that they find themselves in, and kind of draw the strength from themselves rather than externally? Or could we also use peregrinatio to mount a call for action at the systemic level as well? So, thank you.
Thank you. I think we should thank the panelists. Now, I'm very tempted to respond to all these wonderful points in some detail, but I think I'd rather listen others who might have some wisdom on this. Get the mic. Thank you. And I think I will certainly respond perhaps afterwards to these wonderful comments. I'm very appreciative of them, but I'm so grateful everyone's come to spend time talking. So I think Angelica is going to chair this part. Thank you so much. I think that's a wonderful question. I'm really glad there are folks who are in the nursing and other allied health professions here today. It's definitely meant to be aimed at a multidisciplinary team, and as I said before, including in that team medical secretaries, hospital assistants, managers, and even the Secretary of State for Health, in a way, I suppose. But I suppose at the granular level, I'm definitely interested in, let's take occupational therapists. Listening to occupational therapists, as I was saying to a colleague just before, there's that sense of holding a narrative which goes before the encounter in hospital, and then back into the wider civic life that they're part of. So that capacity to hold a story, which may be harder for some doctors than others, is absolutely essential to my account of compassion. That it's a relational, social activity or event, as one of my colleagues was saying. In the literature, the emphasis in the nursing literature I've found is around quite a subtle account of time. Often time is the thing which people say they don't have to be compassionate. But some of the nursing literature, I think from an Edinburgh context actually, was emphasising that it's not necessarily the amount of time you have, but of course the quality that you put into that time. And the reviews of nursing material on compassion emphasise that repeatedly. So my account, I hope, has learnt from all the different kinds of actors. Of course, we might include the patient in the team as well for some. So that's a great question, but I hope it's compatible. Others will have to judge. Oh, these are great questions. I'm going to do the first one very briefly because it's a great question, but we could go on at great length. So the primary way that I talk about healing in the book is about the healing of affections. And that compassion as a kind of ongoing social event is to do with the healing of the affections, our sorrows, our joys, our lament, our fear, our horror. That's the kind of encounter which is possible in a healthcare context can conduce toward the healing of affections. Cure I take to be a much more biomedical focus. Now the two are related, they're not completely separate, it seems to me, because the healing of the affections may be contingent on how people approach cure or the effectiveness or otherwise of a curative course. That's brief. Now this question is very important. This is one of the things I learned about very quickly in the vascular context. So listening to the way that, so this was in the vascular surgical context in the JR, listening to the way that patient interactions between clinicians, healthcare staff and others mattered very, very greatly to the kind of culture, to the ethos of that department. Graham's already mentioned, in a sense, the kind of continuity of care and the kind of satisfaction which comes from an ongoing relationship. You're perhaps bringing to the surface the more negative side, which is completely understandable, which is what I saw perhaps in the vascular context, which is a lot of very so-called difficult patients, and that I'm afraid is a phrase which is used, and a patient who, or group of patients who, your term, moan or make it very difficult and don't actually recognise the vocational effort perhaps of healthcare staff. I don't know if I'm framing your question reasonably well, but that was a real sort of source of trouble and endurance for colleagues who I was working alongside as to how you keep going. And that perhaps touched a bit upon the question of desert, Richard, which you were raising, as to how, as it were, when a patient in some way looks like they are causing unnecessary trouble That's what I heard from colleagues. How you move past that without allowing that to be a stop on the care which you provide.
Oh, I see. So you were observing it rather than defending it.
There needs to be a way of framing it which recognises wrongdoing on any party. Wrongdoing by clinicians, wrongdoing, yes, by patients. There can be violence or unpleasantness from patients to staff. And so I think the difficulty really is if you have an account of compassion which completely ignores wrongdoing and responsibility, it seems to me it doesn't fit with the actual practice of healthcare. How you prevent it being a block and actually provide a sort of conceptual frame for it is, I think, the challenge. Compassion is two-way, and it persuades doctors as well, and nurses and midwives, as well as persuasion being one way. Sorry, Angelika, yeah. Who else wants to come in? Yeah. So thank you for that. I see healthcare as essentially a civic endeavour, and social care brings that wonderfully to the surface. So chapter 4 of the book aims at that territory, that we don't think of healthcare, as it were, as a city on a hill, away from the cut and thrust and every day of life. And so what I think about as a basic training for people in social care is to think about citizenship. But actually what we're doing is sort of side-by-side citizenship in social care, or quasi-citizenship, especially treating neighbours who aren't citizens as if they were citizens. That would be a starter, but not a great finish. I'm sorry. Shall I make some final remarks? Is that all right? Just to say a few thank yous. Oh, hang on. This is first to advertise some events coming up, which are really emerged from Torch and from all the work which was kindly incubated here. So these events are coming up. You're extremely welcome later in this month. Public lectures for free here and here, and a conference on the left-hand side. And I just want to say lots of thank yous in one slide to all these folk, but especially my wife Claire, who I want to acknowledge as being absolutely central to the writing of this book. But loads of people to thank, and thank you to Torch very much indeed.
Right.